The following podcast is part of a certified educational activity titled Improving the Care of Patients with Hereditary Angioedema, Maximizing Protection with Long-Term Prophylaxis. Access the entire activity and complete the post-test at peerview.com/SPC860. Downloadable slides and practice aids are also available.
Hello, and welcome to this educational activity on improving the care of patients with hereditary angioedema, maximizing protection with long-term prophylaxis. I'm Alina Banerjee from Harvard Medical School and the Clinical Director of Allergy and Immunology at Massachusetts General Hospital. Our goals for today are to augment your knowledge of the unmet needs of patients living with HAE and current challenges and barriers related to long-term prophylaxis. We also hope to improve your understanding of novel and emerging options for long-term prophylaxis. We want to equip you with strategies to educate patients with HAE on the benefits of long-term prophylaxis and how to manage any adverse events. And finally, to provide guidance on creating individualized treatment plans for individuals with hereditary angioedema. Our first module will go over the background of hereditary angioedema and talk about the optimal approach to treatment and burden of disease for patients with hereditary angioedema. To get us started, let's first talk about the difference between bradykinin-mediated angioedema and histamine-mediated angioedema. In general, the severity of swelling and duration of swelling tends to be greater and longer with bradykinin-mediated angioedema, where symptoms will last for 3 to 5 days when it's untreated. In contrast, histamine-mediated angioedema tends to last only a few hours and almost always improves within 24 hours. While the risk for fatal airway obstruction is certainly present in both situations, it is far more severe and appreciable with bradykinin-mediated angioedema. We also see that abdominal attacks with abdominal pain, abdominal swelling, abdominal bloating, which can also last for 3 to 5 days, is far more common and seen in patients with bradykinin-mediated angioedema. And in terms of treatment, which we will spend a lot of time talking about, there is almost no benefit to using antihistamines, corticosteroids, and epinephrine in bradykinin-mediated angioedema, and this is in sharp contrast to our typical allergic symptoms or histamine-mediated angioedema or histamine-mediated allergic reactions, where the cornerstone of treatment is antihistamines, corticosteroids, and epinephrine. So what is hereditary angioedema? This is a debilitating, potentially life-threatening genetic autosomal dominant disease, and it's caused by an inherited deficiency of the C1 esterase inhibitor protein. As it's a genetic condition, almost all patients will have symptoms by the time they are teenagers. So symptoms typically will develop in childhood or young adulthood by the time you finish your teenage years. Classic symptoms involve the airway, and these are certainly the most concerning because of the risk for airway asphyxiation. Patients will also have a broad category of what we call peripheral swelling, which is recurrent swelling of the hands, legs, and abdomen. And then gastrointestinal swelling or abdominal symptoms, where patients frequently have nausea, vomiting, and diarrhea. Along with airway swelling, you can often see face swelling, tongue swelling as part of that category. The biggest concern is when there is airway swelling. If untreated, the risk of asphyxiation and mortality is very high. We also know that there are some common triggers such as stress, trauma, infection, menstruation, exogenous estrogens, or ACE inhibitor use. But 2/3 of the time, there is often an unidentifiable trigger for these attacks, which is part of the reason why these spontaneous attacks can be such a negative impact on quality of life for patients. So as I mentioned, clinical presentation is recurrent episodes of swelling that are often spontaneous. The swelling can be peripheral, abdominal, or airway, and lasting for 3 to 5 days when it is not treated. When we're talking about diagnosis and classification, there are two main types of hereditary angioedema. Type 1, where the C1 inhibitor level and C1 inhibitor function are low, and you often also see a low C4 level. 75 to 80% of patients have hereditary angioedema with C1 inhibitor deficiency type 1. About 20% of patients have what we call hereditary angioedema with C1 inhibitor deficiency type 2, where the C1 inhibitor level is normal because they are producing the protein, but the C1 inhibitor function is low because the protein that is produced is dysfunctional. And so that is why it is important to always check for the C1 inhibitor function. Otherwise, you will miss about 20% of cases, which are these individuals with hereditary angioedema with C1 inhibitor deficiency type 2. And extremely rarely is what we call hereditary angioedema with normal labs, where patients do not have a low C1 inhibitor level or a low C1 inhibitor function. However, the clinical symptoms are the same, and this is a bradykinin-mediated pathophysiology. We have identified several different genetic mutations that lead to bradykinin-mediated angioedema in these cases. In terms of the diagnostic criteria, for hereditary angioedema with C1 inhibitor deficiency, which I mentioned as type 1 and type 2, the required criteria are a history of recurrent angioedema without urticaria or use of a medication known to cause angioedema. Patients have a low C1 inhibitor function, typically below 50% of normal, and a low C4 level, and this can be at baseline or during an attack. Supportive criteria for hereditary angioedema with C1 inhibitor deficiency is either demonstration of a pathologic SERPING1 mutation, a family history of angioedema, or age of onset of symptoms much younger than 40 years of age. In contrast, there are different criteria for patients with hereditary angioedema with normal labs. And as the name says, they have normal labs including a normal C4, a normal C1 inhibitor level, and a normal C1 inhibitor function. These patients also must present with recurrent episodes of swelling without urticaria or use of a medication known to cause angioedema. And part of the required criteria are demonstration of a mutation associated with the condition or a positive family history of recurrent angioedema and lack of efficacy with high-dose antihistamine therapy, typically 4 times the normal dose. Supportive criteria for hereditary angioedema with normal labs is a history of rapid and durable response to a bradykinin-targeted medication and predominant documented visible angioedema or objective symptoms of swelling. And in patients that have predominant abdominal symptoms, this could be documented by CT or MRI with bowel wall edema. Before we talk about treatments, it's important to understand the plasma kallikrein-kininogen pathway. We start with factor 12, which is activated and becomes activated factor 12. Activated factor 12 then acts on prekallikrein to form kallikrein. Kallikrein not only has a feedback loop on activating factor 12, but also leads to bradykinin generation from high molecular weight kininogen. Bradykinin is the key mediator binding to the B2 receptor on vascular endothelial cells, causing an increase in vascular permeability. In normal individuals, healthy individuals who do not have hereditary angioedema, we have normal levels of C1 inhibitor protein, which inhibits this pathway, and you have inhibition of bradykinin generation. When we lose the C1 inhibitor protein, such as in individuals with hereditary angioedema, you do not have inhibition of the pathway, and therefore unregulated production of bradykinin or elevated levels of bradykinin, which then bind to the B2 receptor and increase vascular permeability, causing the symptoms of angioedema that we see in these individuals with hereditary angioedema. When we think about treatment of patients with hereditary angioedema, we have to talk about the burden of disease. The disease course is complicated. Patients have symptoms very early on, but often misdiagnosed or delay in diagnosis of hereditary angioedema, and we know that this is a chronic condition. In addition, we have to think about the nature of these attacks. We mentioned that they're unpredictable, they're prolonged, they can be frequent. These episodes of swelling are often painful, debilitating, disfiguring, and when they involve the airway, are certainly life-threatening. Burden of having hereditary angioedema is also about treatment options. Even with available treatment options, insurance can sometimes make it very difficult to access these treatments. They often can have side effects that we have to talk through with our patients. And quality of life has a big impact when we're talking about our patients. When attacks can be unpredictable and can have such an impact on their day-to-day, we have to think about the symptoms of depression and anxiety in our patients. We have to think about the impact on social activities, travel, work, and if they've needed urgent care or hospitalization, and that impact on their day-to-day. And last but not least is certainly the costs. It's not just about the cost of medication, but it's about the indirect costs, such as loss of work or school productivity. Hospitalization, emergency room visits are also part of the costs that we have to think about for our patients. And what we know is that rates of anxiety and depression in our patients with hereditary angioedema is extremely high. In a survey conducted a few years ago by the U.S. HAE Association, we saw that in over 445 patients, half experienced some form of anxiety, and about 24% exhibited some symptoms consistent with depression. And this is much higher than what we see in the normal population. And not only were these symptoms present during HAE attacks, but they were present at baseline because patients with hereditary angioedema don't know when the next attack will occur, even if they're avoiding triggers, and they don't know what part of the body will be swelling. And there's also significant fear associated with that potential fatal laryngeal attack which could develop. And we know that at least half of patients with hereditary angioedema will have a laryngeal attack at some point in their life. There are numerous guidelines that have been developed, including the WAO-EACI guideline, the U.S. Hereditary Angioedema Association guideline, the pediatric guideline, the Canadian Hereditary Angioedema guidelines, but these are all consistent with some core principles on how to approach patient care for our patients with hereditary angioedema. This includes thinking about acute attacks, long-term prophylaxis, as well as short-term prophylaxis. And the goals for acute attacks is to resolve angioedema symptoms as quickly as possible during an attack, which means to treat every single attack and to treat the attack as soon as the attack symptoms are recognized. In terms of long-term prophylaxis, all patients with hereditary angioedema are candidates for long-term prophylaxis, and the goal is to decrease the overall number and severity of attacks. And then short-term prophylaxis is really to reduce the likelihood of swelling in response to anticipated events that are likely to precipitate an angioedema attack. This will include dental work, upcoming surgery, and for us to think about short-term prophylaxis in these cases for all of our patients with hereditary angioedema. In terms of on-demand treatment recommendations, again consistent across all of the guidelines that I mentioned, is that evidence demonstrates efficacy and safety of treatment of HAE attacks with all of the currently available treatments, which includes C1 inhibitor concentrates, plasma kallikrein inhibitors, and bradykinin B2 receptor antagonists. Fresh frozen plasma is certainly effective and can be used if none of these other treatments are available, but caution is required because fresh frozen plasma contains the mediators that can lead to increased bradykinin generation and could aggravate an ongoing attack. Androgens and antifibrinogens should not be used for on-demand treatment. We also know and have mentioned that epinephrine, corticosteroids, and antihistamines are not effective in the treatment of attacks in patients with hereditary angioedema. And so all patients should treat attacks with on-demand treatment as soon as it's recognized, and all patients should always have at least 2 doses of on-demand treatment on hand at any one time, and we should be encouraging patients to treat at home and self-administration because the sooner they treat the attack, the better the symptoms will respond. In terms of long-term prophylaxis, there are a variety of factors that we think about. This includes clinical factors in terms of attack frequency and severity, disease burden factors, which include a variety of quality of life metrics, disease control, access to treatment and on-demand treatment, as well as urgent care if they were to have an attack. And then to think about treatment-specific factors, risk-benefit profile, treatment properties such as route of administration, and patient preference. But the core principles, similar across all of the guidelines that I mentioned, is that all patients with hereditary angioedema are candidates for long-term prophylaxis. Disease burden and patient preference should be part of shared decision-making with every patient. The guidelines were written before FDA approval of a variety of treatments, and so the general approach is that C1 inhibitor, as well as garadacimab, lanadelumab, berotrostat, and donidalorsen are all first-line treatment for long-term prophylaxis in patients with hereditary angioedema. Once a decision is made, these are decisions that should be revisited during regular, ongoing care over the long term with our patients, and that modification and changes in long-term prophylaxis can occur based on patient-specific factors, including their burden of disease and quality of life at each visit. Now, why is shared decision-making important? We know that it improves patient understanding of treatment options and is very important in our ongoing decisions around long-term prophylaxis. We also have seen from data that patients have increased confidence in decisions when we use shared decision-making, and patients are far more knowledgeable about their condition and can monitor themselves when we use shared decision-making. And so what does shared decision-making mean, and how do we engage patients in shared decision-making? So first, we think about discover, which is exploring the patient's needs. What is their perspective? What are their goals? How do we meet their goals? And how do we do that acknowledging the availability of options that we have for that patient? Then a discussion. What are the treatment options? How can we use them? Does this align with the goals that we've talked about? And then we can develop some informed preferences through a discussion model. And then third, we think about deciding. So how do we make shared decisions based on the information that was discovered and discussed? And then we go back through this cycle at every visit and we understand, did what we decide work? Is it meeting your goals? Do we need to discuss again what are different alternatives? What is working? What is not working? And all of this should include the variety of things that we talked about as part of burden of disease. That should include things like cost, quality of life. Are there factors that are working? Are there factors that aren't working? Have things changed? And we continue to use the discover, disguise, decide model to engage patients in shared decision making. So as we think about long-term prophylaxis, we also have to think about what are the barriers for our patients. This includes treatment access and availability, route of administration and treatment burden, such as is it intravenous, is it oral, is it subcutaneous? What is the patient perspective on that? What about adherence and persistence? So is something daily, and is a patient preferring something daily? Is something every several weeks, and is that easy for the patient, or is that more complex? What are the safety and tolerability concerns for that individual? Are they needle phobic? Do they have side effects such as abdominal pain from using a medication? What is the impact on quality of life for that individual? Has their quality of life improved? Has it stayed the same? Is there ongoing anxiety about breakthrough attacks? What are some health system barriers? If they were to have an attack, where would they go? Do they have challenges with insurance? All of these are things that need to be discussed as part of shared decision making when we're talking to that individual about long-term prophylaxis. Thinking about that, I want to bring up the PIONEER study, which looked at discontinuation rates in real-world use of long-term prophylaxis. And what they actually found that discontinuation rates were actually pretty high. So in this study, they looked at 179 patients between 2021 and 2024, and initial long-term prophylaxis was about 55% with kallikrein inhibitors, 37% on C1 esterase inhibitors, 6% on androgens, and 2% on antifibrinolytics. And certainly this study was done at a time when some of the newer long-term prophylactic agents were not available. And what they found was that 46% discontinued their initial index prophylactic therapy within a median of 12 months or within a year for a variety of clinical and non-clinical factors. And so we do have to be aware that these are real world data suggesting that we have to think about reasons why a patient might discontinue their therapy, and it can be clinical and non-clinical. And so how do we overcome these barriers with our patients? And certainly two-way communication is going to be very important. We have to emphasize the benefit of long-term prophylaxis, reducing attack frequency and severity, decreasing complications when attacks occur, and helping patients understand that our goal is to help them normalize their day-to-day life. We also have to think about their fears and highlight real-world data showing that long-term prophylaxis has sustained quality of life improvements. We have to address their concerns transparently. We can say that most long-term therapies are well tolerated and that common side effects like injection site reactions are mild and decrease over time. However, that may not be true for every single patient, and we have to maintain open communication, understand if there are new bothersome symptoms, and we have to ask them to communicate with that promptly to us. We can ask patients to keep a symptom diary, track timing, severity, and potential triggers, and communicate it to us. We can also help them adjust their administration technique if they're having significant injection site pain or local reactions, and encourage things such as rotating the site to minimize injection site reactions locally. We can also give them supported measures such as ice pack, topical anesthetics, lower infusion rates if it's applicable. But we cannot do that if we don't understand that these are barriers for that individual. We can also reassure that patient with a monitoring plan. We'll check in frequently and manage any side effects, and that can be done through regular follow-up visits and lab monitoring if it's appropriate. We can share updates on quality of life and tolerability with that individual at each visit. We can continue supportive care for mild adverse events. We can use over-the-counter remedies such as antihistamines or topical hydrocortisone if it's appropriate. We can encourage patients to stay well hydrated, maintain a healthy lifestyle, reduce fatigue or headache risks. We can individualize treatment adjustments, which can include discussing dose timing or regimen adjustments if adverse events are interfering with daily life. And we can explore alternative prophylactic agents if adverse events persist or worsen. And certainly emergency preparedness is going to be very important, and ensuring that on-demand therapy is always available in case of attacks, and at least 2 doses of on-demand therapy, and always having an action plan. So where should they go? Who should they call? What should they do if they need to use on-demand and they don't have it, or they use on-demand and the attack is ongoing, and what to do if they have life-threatening symptoms. In Module 2, we're going to review emerging therapies for long-term prophylaxis in patients with hereditary angioedema, and to think about how can all of the newer agents support our patients in their care. In the United States, we are fortunate to have multiple drugs available to our patients for long-term prophylaxis. I will spend a few minutes going over each of these. First, we have a C1 esterase inhibitor replacement product, which can be given either subcutaneously twice a week or intravenously twice a week. The subcutaneous agent is dosed at 60 international units per kilogram, given twice weekly, and approved in adults and children down to 6 years of age. The intravenous C1 inhibitor replacement therapy is given as 1,000 international units twice weekly and approved in adults and adolescents greater than 6 years of age. For our subcutaneous replacement treatment, the COMPACT study, or the pivotal phase 3 study, showed an 84% reduction in attack compared to placebo. For the intravenous C1 inhibitor replacement product, the phase 3 study showed greater than 50% attack reduction compared to placebo. Berotralstat is a plasma kallikrein inhibitor given orally at 150 milligrams once a day for prophylaxis in adult and adolescent patients down to 12 years of age. In the APEX-2 study, we saw there was a 44% attack reduction compared to placebo with sustained efficacy at 48 weeks. Some patients prefer the oral option, and it is a once-daily treatment. Lanadelumab is another long-term prophylactic agent, which is a plasma kallikrein inhibitor, a monoclonal antibody to active plasma kallikrein, dosed subcutaneously at 300 milligrams once every 2 weeks or once every 4 weeks, approved in adults and children down to 2 years of age. The pivotal phase 3 study, the HELP study, showed an 87% mean attack reduction compared to placebo, and the SPRING study, which was lanadelumab in children ages 2 to 12 years of age, showed almost a 95% attack reduction compared to placebo. The last two drugs, garadacimab and donidalorsen, were most recently FDA approved in the United States in 2025. Garadacimab is a factor XIIa inhibitor dosed subcutaneously 200 milligrams every 4 weeks after an initial loading dose. It's approved in adults and adolescents greater than 12 years of age. The pivotal phase 3 study, the Vanguard study, showed an 87% mean attack reduction, and the open-label extension had a 94% reduction with 57% attack-free over 1.2 years. And donidalorsen is an antisense oligonucleotide targeting prekallikrein, dosed subcutaneously at 80 milligrams either every 4 weeks or once every 8 weeks, and it's approved in adults and adolescents down to 12 years of age. The pivotal phase 3 OASIS Hereditary Angioedema studies showed an 81% reduction in attacks compared to placebo. I'll spend the next few minutes going over the data for some of the key pivotal phase 3 studies for the recently approved long-term prophylactic agents. So I'll start first with berotralstat, which is the oral kallikrein inhibitor, dosed once daily. And the phase 3 study was the APEX-2 study, which enrolled 121 patients at least age 12 years of age. They were dosed at either 110 milligrams once daily, 150 milligrams once daily, or placebo over a 12-week period of time. And what they found is that berotralstat at the 110 milligram dose decreased attack rate by 30%, whereas the 150 milligram dose decreased attacks by 45% compared to placebo over the 24-week study period. These data led to the FDA approval of this once-daily medication down to 12 years of age. Side effects that have been reported with berotralstat include gastrointestinal symptoms, particularly in the first several weeks, but often resolve with continued use of berotralstat. The next drug is lanadelumab, and the pivotal phase 3 or HELP trial studied 125 adults and adolescents greater than 12 years of age. They studied lanadelumab at 150 milligrams every 4 weeks subcutaneously, 300 milligrams every 4 weeks subcutaneously, or 300 milligrams every 2 weeks subcutaneously compared to placebo over a 26-week study period. What they found is that lanadelumab at the highest dose, or the 300 milligrams every 2 weeks, decreased the attack rate by 85% compared to placebo, and that 40% of patients receiving lanadelumab were attack-free during the 26-week study period, compared to only 2% receiving placebo. The most common adverse event was mild injection site reactions during this study. In the spring study, we looked at lanadelumab in children aged 2 years to 12 years. Similar to the pivotal phase 3 study in adolescents and adults, there was a significant decrease of almost 95% over the 52 weeks of treatment compared to the baseline attack rate. 76% of patients were attack-free, where 99.5% days were attack-free. Similar to lanadelumab in adults and adolescents, the most common adverse effect was injection site pain, but there were no serious TEAEs and no discontinuations due to TEAEs. With garadacimab, the pivotal phase 3 study was the Vanguard study, published in 2023, led by Dr. Tim Craig in The Lancet. In this study, they enrolled 65 patients with hereditary angioedema of at least 12 years of age. Garadacimab was studied at 200 milligrams every 4 weeks subcutaneously after an initial loading dose and was compared to placebo over 6 months. And what you can see is a significant reduction in the attack rate compared to placebo, leading to the approval of garadacimab dosed once every 4 weeks subcutaneously. We also saw that 62% of patients were attack-free with garadacimab during the 6-month treatment period. And the last and most recently approved FDA drug for long-term prophylaxis in patients with hereditary angioedema was donidalorsen in the OASIS Hereditary Angioedema trial. In this study, a total of 90 patients received donidalorsen every 4 weeks or every 8 weeks, and this was compared to placebo. And what you see is a significant decrease in the attack rate in patients on donidalorsen every 4 weeks and every 8 weeks compared to placebo. The most common adverse event that was reported was mild injection site reactions. In conjunction with the improvement in efficacy compared to placebo, there was also an improvement in the AE-QoL domains across functioning, fatigue and mood, fears and shame, and nutrition for the 80 milligram dose every 4 weeks and the 80 milligram dose every 8 weeks compared to placebo, and a matching improvement in ACPE total score when you looked over the 24 weeks of the study. When we're assessing disease control in our patients with hereditary angioedema, there are several validated tools. This includes the Angioedema Activity Score, or the AAS, the Hereditary Angioedema Activity Score, or the HAE-AS, and the Angioedema Quality of Life Questionnaire, or the AE-QoL. Each of these has a different number of items and a slightly different recall period, but they are useful in trying to understand the quality of life impact and following that over time. The Angioedema Activity Score has 5 items with a recall period of 24 hours, And its advantages are that it's brief with good internal consistency, but it does have prospective nature limitations of compliance. The Hereditary Angioedema Activity Score has 12 items, and the recall period is either 1 month or 6 months, and it allows for assessment of attack variability over time. However, it's a disadvantage if you're trying to recall information over 6 months. The angioedema quality of life, or the AE-QoL, was studied in recurrent angioedema, has 17 questions with a recall period of 4 weeks, and its advantages are it's a good psychometric properties and good internal consistency, but it is not HAE specific and can be time consuming because of the number of items. However, these are all useful tools when we follow our patients over time and are able to follow the score over time to really understand the quality of life impact or potentially the quality of life improvement as we're following our patients on treatment. So when we're thinking about our patients and they have a low quality of life or suboptimal control using these tools, we have to think about when do we think about switching treatment. For example, switch if current long-term prophylaxis fails to reduce attacks by greater than 50% or improvement in quality of life. Then what do we do at that time? Do we think about transitioning to different therapies targeting different pathways? Or is it about the mechanism of administration? Or is it side effects? And then certainly monitoring them for several weeks or several months after the switch to understand if that treatment improved their quality of life and their disease control. So in this study published in JACI in Practice in 2025, led by Dr. Mark Rydell, looked at patients with suboptimal control on long-term prophylaxis to understand if they would benefit from a switch in treatment. So patients with hereditary angioedema on prior long-term prophylaxis, which could have included lanadelumab, berotralstat, or C1 inhibitor for prophylaxis, had a baseline assessment and then were switched to 80 milligrams of donidalorsen given every 4 weeks for a period of 16 weeks, and then they were assessed at the week 16 of donidalorsen treatment. And what the study found was there was an acceptable safety profile. There was a reduction in hereditary angioedema attacks by 62% in these individuals, improved quality of life, improved disease control, and in this specific study, preference for donidalorsen in 84% of patients, taking into account that these were individuals that had suboptimal control on their prior long-term prophylactic treatment. In terms of looking forward, there remain several different treatment options that are emerging and under study for patients with hereditary angioedema. This includes deucrictibant, which is an oral bradykinin receptor antagonist being studied in adults and adolescents greater than 12 years of age. Navenibart is a plasma kallikrein inhibitor given subcutaneously every 3 months or every 6 months being studied in adults. Also, NTLA-2002, which is a CRISPR-Cas9 gene therapy being studied in adults in a phase 3 study, and EDRX, currently in phase 3 study as another long-term prophylactic option for patients with hereditary angioedema. So certainly multiple therapies in addition to the currently available treatments being studied for long-term prophylaxis for our patients with hereditary angioedema, making the horizon very exciting and very bright for our patients. Let's talk through a few different cases to understand how to put all of this together in terms of thinking about burden of disease, quality of life, shared decision-making in an arena where we have multiple different treatment options for our patients with hereditary angioedema. So the first case is Gary, 35-year-old male who has hereditary angioedema who reports 3 to 4 attacks a year for the past couple of years. His swelling is usually in his hands and feet after being at his construction job all day. In all of his prior visits, he's really felt that on-demand medication is his preferred choice, and he has not wanted to use long-term prophylaxis and has felt that using on-demand medication right away has worked well. However, he presents today, and on follow-up and in his discussion, he says that he anticipates a job with more travel, and he's trying to understand if there are other ways to approach his treatment. And so how would you advise him? In terms of shared decision-making, we would certainly talk to him and explain that all patients are eligible for long-term prophylaxis. And as part of this conversation, you start understanding that his on-demand medication regimen hasn't been as easy as he has been saying. He often has to step away from the construction job to find a place to administer his on-demand medication. He has missed several days of work because of having attacks that he didn't treat early enough because he was at work and didn't take his on-demand medication with him. And so as you talk to him about travel and all of the challenges that he's had with on-demand medication, you talk to him about the different mechanism of action, which doesn't necessarily interest him that much. He instead prefers a subcutaneous medication for long-term prophylaxis now compared to the oral options. And so we talk through the different agents for long-term prophylaxis, and he prefers to use something subcutaneously that is infrequent. We decide to go ahead with the long-term prophylactic subcutaneous option for him and suggest that he come back for follow-up in 3 to 6 months. Our next case is John, the 54-year-old male who presents to your clinic with a diagnosis of hereditary angioedema with C1 inhibitor deficiency, diagnosed around the time of childhood. In the last decade or so, he's been using icatibant for on-demand treatment of his hereditary angioedema attacks. This has been working well, but recently notes an increase in attacks, and he wonders if it's because he has 2 teenagers and he feels that there's a lot more stress. And so previously he would have 1 attack a month or 1 attack every other month, but now tends to have 2 to 3 attacks per month. And his attacks often involve his hands and feet. He also certainly worries about laryngeal attacks and brings that forward today. He would like to understand how to think about treatment for his hereditary angioedema with C1 inhibitor deficiency. And so we talk through his prior use of on-demand treatment, and it's certainly been working well for him, and he is able to use it at the early onset of the attack. And up till now, he has really not had any insurance challenges. However, with the increase in his attack rate, he wants to know what are the different options for long-term prophylaxis. We again use shared decision-making and talk to him about the variety of different treatment options that are available to him now in 2025, including the once-a-day oral treatment option and the subcutaneous options that go from twice a week out to every 4 to 8 weeks. And in his mind, he would prefer to use a subcutaneous option, something that would be infrequent, because he does not think he would be someone who would be good at remembering to take an oral medication once a day. And he certainly says that he would prefer to use a subcutaneous option that's dosed infrequently. He chooses to go on the most recently approved agent that is given once every 4 to 8 weeks. After discussion, the decision is made to start at every 4 weeks with a follow-up in 6 months. When he presents back in the office at his follow-up at 6 months, We talked through his symptoms, and it sounds like he really did not have any attacks and did not use his on-demand since his last follow-up. At that visit, there is ongoing conversation to understand if he would actually like to extend his prophylactic agent out to every 8 weeks and then have him come back for follow-up. Our next case is Maria, a 29-year-old woman with hereditary angioedema diagnosed at the age of 17. And she has a family history with both her mother and her brother having hereditary angioedema. Before starting prophylaxis, she averaged 3 to 4 attacks a month, often requiring on-demand IV C1 inhibitor treatment, causing her to miss school and work. For the last 18 months, she has been on subcutaneous C1 inhibitor twice weekly with a very good initial response, but more recently is averaging about 2 attacks per month, often abdominal attacks or peripheral swelling. On further discussion, she also finds that the administration burden is pretty high. She has to plan ahead for giving herself the injections. She's also talking now about needle fatigue after using this treatment for 18 months, and also really having a lot of injection site pain and discomfort, even though she has been rotating the sites. We talked to her a little bit more about the impact on daily life, and she says that she works as a teacher. She often has to miss school due to attacks, and this has created increased stress with her employer. She continues to have a lot of anxiety about unpredictable attacks, particularly when she has a busy school day or if there's a field trip where she has to travel. She does say that her quality of life has improved quite a bit since being on long-term prophylaxis for the last 18 months, but she still doesn't feel like she has a normal quality of life because of some of the breakthrough attacks and the treatment burden, the anxiety around missing school, and the stress around that. So in our conversations and shared decision-making, we certainly feel she's a good candidate for switching long-term prophylaxis. And why is that? She doesn't seem to have optimal control, or she has suboptimal control. Despite adherence, she has frequent attacks. She does have what she talks about as a high treatment burden, that even though the prophylactic drugs have improved her long-term burden of disease and quality of life, that the regular twice-weekly injections are impacting her lifestyle and leading to adherence fatigue. And she wants to talk about alternatives, and she's interested in the newer options. And you again talk to her about all the different options, including the once oral daily treatment, as well as the subcutaneous options, which could be once every 2 or once every 4 weeks, and talk to her about the different options and the different side effects, and she can choose what is best for her with a follow-up appointment to talk about, did it work? Is there still suboptimal control? Is the treatment burden better? And are there things that we need to continue talking about? After talking about all of the treatment options, Maria chooses to switch to donidalorsen, and she felt that the administration subcutaneously once every 4 weeks or once every 8 weeks might actually be much better for her and decrease her treatment burden. She chooses to go ahead with donidalorsen every 4 weeks, and after 6 months of doing extremely well, she comes back for follow-up, and we have been able to extend her to every 8 weeks with good control of decreased treatment burden and decreased attack rate. And she notes that she went from 2 attacks a month to less than 1 attack every 2 to 3 months, and she's had attack-free stretches of over 12 weeks, which is really good for her. She's really happy about the decrease in on-demand treatment. She has not had any adverse effects, although she notes occasional mild injection site erythema, but it improves on its own without any treatment. And so she's very satisfied on follow-up as we've seen her change her treatment and improve her overall quality of life and decrease her treatment burden. She hasn't had to miss any school days since switching treatment. She feels far more comfortable traveling or going on field trips because she doesn't necessarily feel like her attacks are as much of an issue. She's sleeping better. She has a greater sense of independence. She feels a lot less anxiety because her attack rate has decreased. And she feels that she has a lot more freedom and everything is much more manageable, going from twice weekly injections to dosing every 4 weeks and now dosing every 8 weeks. And so in summary, we know that our patients with hereditary angioedema have a high burden of disease and their quality of life is significantly impacted. We reviewed data showing that this is a debilitating, potentially life-threatening disease, and that our patients with hereditary angioedema have high rates of anxiety and depression and poor quality of life. However, when we look at the guidelines, they are very consistent, and all patients should be considered for long-term prophylaxis, and we have to use shared decision-making with ongoing monitoring, thinking about quality of life assessment, using the tools that we have with ongoing follow-up and open communication so that we can understand how to continue to improve care for our patients. We have multiple novel agents currently FDA approved for patients with hereditary angioedema and several on ongoing studies. We have seen that these are improving efficacy, decreasing treatment burden, and that we can think about switching long-term prophylactic treatment in our patients with suboptimal control or high treatment burden. A patient-centered approach is really effective, tailoring therapy to patient lifestyle, preferences, and disease control, addressing their barriers such as administration burden, adherence, or access, and really helping empower our patients through education, ongoing monitoring, and making sure that they have an emergency action plan if they were to have an attack and what to do if they have a life-threatening attack. Thank you so much for joining us today. I hope you found this activity to be useful in your practice and your care of patients with hereditary angioedema.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Ionis Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/SPC860.